So we're doing live surgery here on a 24-year-old soccer player, right knee, an ACL reconstruction, standard incision over the pes anserinus, longitudinal coagulation of the vessels over the pes anserinus, coming from the infrapatellar branch. And we're going to do a quadruple semitendinosus hamstring graft. So we loop a cysticus clamp underneath the semitendinosus, and we'll use that as a graft. By the way, that's our standard graft, and we believe it's the first choice graft, especially for athletes, because it has very low morbidity and it gives excellent stability. We insert a running baseball stitch through the distal aspect of the graft in order to help for prelevation and also to provide a first suture for fixation later on the tibial side. Once this suture is placed, we detach the semitendinosus from its insertion onto the tibia, and we perform the dissection in order to get a clean tendon graft. And we make sure that we liberate all the adhesions between the semitendinosus and the sartorius fascia, but also some adhesions that are usually present between the semitendinosus and the gracilis tendon, which you can see nicely being liberated here. And also the vinculi going to the gastrocnemius fascia. It's important to dissect these out very carefully. Once that is done, the semitendinosus tendon presents very nicely, and we can pass the sutures through the stripper and proceed to the stripping of the tendon in a gentle way, by pulling on the graft and pushing forward onto the stripper. And this usually gives you a very nice graft. Like here, this looks excellent. It's a thick tendon, so this will be a quadruple. This will be transformed into a quadruple strand, which will probably end up with 8 or 9 millimeters in thickness. So that is great. Once we've done that, I like to close the sartorius fascia because I think it helps in regeneration of the semitendinosus tendon later on, which is important, especially in athletes, because they really need strong hamstrings afterwards. So this is done with a standard Vicryl O suture with interrupted sutures. Okay, once this is done, we go inside the knee. The scope in the anterolateral portal and the anteromedial working portal. And once we're in the knee, you see here the ruptured ACL. Initially, this patient opted for conservative treatment, but that didn't work. He stayed unstable and decided to go for surgery finally, which I think is by far the best option for him as a soccer player and as an athlete. And you see here that the remnants of the ACL have become somewhat fibrotic, but are still there. Meniscus looks fine. We knew that already from the preoperative MRI, but still we want to check that during the procedure by probing the meniscus and looking for a ramp lesion. Here you see the stump of the ACL, which has become fibrotic, but it's blocking extension of the knee, as you can see. And here the lateral meniscus, that looks fine. You see the popliteus tendon there in the back. A little bit of gapping on the lateral compartment here, which is not unexpected because this patient also has a tear in his ALL, his anterolateral ligament, which we will fix at the end of the procedure as well. We believe that it's really important to address the anterolateral ligament. Otherwise, your re-rupture rate is way too high. So first, some cleaning and removal of the remnants of the ACL because they are in the way. They, as I said, they block extension of the knee, so we need to clean that up first. All this scar tissue. and the former stump of the ACL. You see that this patient has a very narrow notch, so I will probably do also some notchplasty to make sure that our new ACL has sufficient place and doesn't get nicked off in case of a new trauma. Because we know that a small notch or a narrow notch is a contributing factor to tearing of your ACL. So this is, I do that with a full radius shaver. You see we open slightly the notch to give more space for the reconstructed ACL so that it doesn't get nicked off. We do this shaving under suction, so the debris is immediately sucked out of the knee and doesn't stay floating around in the joint. So usually we're very meticulous with that because we really want to see also very nicely the inside of the notch because we will have to position our femoral fixation tunnel as anatomic as possible. So especially the back side of the notch we really need to see very well. And also cleaning of the footprint on the tibial side with the shaver. This looks already much better and much cleaner and almost ready for preparing the tunnels. Also the back region there needs to be very clear. You see this patient has a very nice PCL. It's in very good shape. There's still some open vessels there, which we will address now with a cautery device. It's an arthrocare device. So we coagulate the open vessels on the PCL. Okay, very well. And also in the back of the knee, usually there are some vessels that we will prophylactically coagulate. Okay, now we're ready. Everything is clean. We're ready to bring in the tibial aimer for making the tibial anchoring hole for the ACL. So for that reason, we drill a tunnel through this device, which is a guiding device. And first we drill a guide pin that we will overdrill with a hollow drill that measures the same size as the graft. So we bring the knee in extension once we've had the pin in place to make sure that it's in the correct position. It's a bit anterior here, so we'll overdrill this with a somewhat smaller drill, and then reposition the pin some 1 or 2 millimeters more backwards, so that it's really in the ideal position. So we fix the pin from inside with a mosquito clamp. And then overdrill, in this case with a 7 millimeter drill. And in the meantime, we know that the graft is 9 millimeter because the nurse told me after measuring. So this is a 7 millimeter hole, and now we'll push the pin backwards in this hole, so we gain another 2 millimeter more to the back. And then we will overdrill this with a 9 millimeter drill, which matches the 9 millimeter of our graft. Here comes the 9 millimeter drill. Okay, it's almost there. Okay, there we are. Okay, again, important to remove all the debris, and we do that immediately so it doesn't start circulating in the joint. And we bevel the edges, the sharp edges of the tunnel, especially on the back side, with this rasp that we bring in from distally, and we clean up again we clean up with the shaver. So this is our tibial fixation tunnel for the graft, and the position looks perfect. Okay. Now the drilling of the femoral tunnel. We use that with an offset aimer with an offset of 6 millimeters, which means that we will have a posterior wall of about 2 millimeters, a little bit higher. So first we make again a trial hole to see whether, to confirm that we're in the perfect place. Yeah, that looks excellent. Yeah. Okay. So we can make this hole permanently, and again, we first use a guide pin, and then we will drill the final hole over this guide pin. Doing it that way, make sure that there is no drifting of your drill once you are drilling, and that you may up inadvertently in the wrong position. So this is a calibrated pin, so we know exactly how deep we have to go, and then we over drill with a 9 millimeter drill. And ideally we want 25 millimeters depth. So this also is a calibrated drill. Usually at this step a lot of bone dust is generated, so the view is blocked somewhat. But still, through the pump and the water irrigation into the joint, we can nicely assess. Okay, this is the 30 millimeter mark, so we're 25. That's excellent. Okay. Okay, so we remove everything again, also the guide pin. And we clean up with the shaver, again to remove all the bone dust. And that we keep the knee nicely clean. So that is perfect. And also here we will bevel the edges of the tunnel with the shaver in order to avoid any sharp edges here that may cut or damage our graft. Okay, so now both the femoral and the tibial tunnel is ready. And that looks very clean. So now we bring in the pin again, because we need to bring in the wires for pulling in the graft. So you see that this pin is passing from the anteromedial tunnel through from the anteromedial portal through the femoral tunnel, and this pin guides the suture, and we will pull up this suture from the tibial tunnel. You see that here. So now this suture passes from the femoral to the tibial tunnel, and through this we can pull in the graft. So here is the graft with the tightrope button there. So this tightrope button will provide a femoral fixation, and it will flip that way. So once it's pulled in through the small tunnel, it's pulled in the longitudinal direction, and once it's reached the second cortex, one of these sutures there is flipped, so that the button comes to lie perpendicular to the cortex and provides fixation to the graft. You can see that on the image here. Okay, so here is the button in the longitudinal direction, so exactly as it should go in, because obviously then it's at its narrowest. Okay, so pulling in. Okay. So and then once you feel it loosens once it passes the second cortex, and then if one of the wires is used to flip the button, so it comes to lie perpendicular to the tunnel and therefore provides fixation. Once it's there, the third wire can be used to pull in the graft. You see that happening here. So now it's really going into the tunnel, and the mark, you see the blue mark on the graft, it's methylene blue. It indicates the 25 millimeter mark. So we need to get the graft in until that mark. So this is excellent. Yeah. So this is our new ACL. Now we're going to check whether it's sitting exactly as it should. So it shouldn't impinge when we bring the knee in extension. It just touch the notch, the top of the notch. That's excellent. Yeah, that is excellent. Yeah. So this knee is going from full extension to full flexion, and the graft stays with perfect tension. So next we're going to do the tibial fixation. We do that with a screw as a post. So we make a perpendicular drill hole onto the tibia, just distal to the tunnel. We measure the length of that tunnel, or I should say we measure the length of that drill hole, and this is a 37 or 37 here. So we bring in a 37 screw, and this screw will serve as a post around which we knot the tapes that are attached to the graft on the tibial side. So here you see that. So it's a quadruple graft, so it means that it has two bundles, and each bundle has two strands, so that means 4 strands. So this is the first bundle that is tight, and this is the second bundle that we're going to tighten now. So one suture on each strand. Okay, 4 knots. Once they're made, we tighten the screw. So that's our first anchorage on the tibial side. A quick check into the joint that everything is fine. Actually, it's perfect here. And then we will do a second fixation of the tibial into the tibial tunnel by using an interference screw. And this interference screw is brought into the tunnel parallel to the graft, so it acts as a compression screw. So we bring in this guide wire, and here you see the screw coming in on the left picture. It's a peak screw, so polyester ester ketone. And we just need to make sure that the screw is not protruding into the knee. So that's why we're looking here at the base of our new ACL to make sure that the screw doesn't protrude into the joint. So, okay, this looks excellent. Yeah. Last check, new ACL in situ, in place, looking perfect. So, this is it for the ACL reconstruction. Final thing to do is to reconstruct the anterolateral ligament. If you want to know more about that, I made a specific video around that. You can find it on our channel. So lateral incision, we dissect onto the iliotibial tractus, and a few millimeters anterior to the posterior margin, we make a longitudinal incision and a second tram line incision, some 13 millimeters more anterior. And then we perform a careful dissection of this ITB strip, as we call it, so iliotibial band strip. And I'm speeding up the video here because it takes a while, and the important thing is that you get a view on how meticulously we do that to make sure that we have a nice solid strip from the ITB, which we will use for reconstructing the anterolateral ligament. Okay, the strip is we're back at the normal speed here. The strip is now nice reprelevated, and we'll put again a baseball stitch in there to help us with bringing in the strip at the location where it should be. Again, this is a Vicryl 1 suture that we use for that. Okay, so here we are. Next, we dissect the lateral collateral ligament. It's an important anatomic landmark because the ITB strip for the ALL needs to be brought under the lateral collateral ligament. You see that here. So we use a mosquito clamp to guide the ITB strip and bring it under the lateral collateral ligament. Make sure it's not twisted. Okay, so this is perfect. So next we coagulate the superior lateral vessels from the geniculate artery so that there is no postoperative bleeding. And we tighten the graft and fix it with a staple slightly anterior to the posterior cortex. And usually this is at the level of where the endobutton is sitting, as you see on the radiograph projected here. So that's it. Now it's basically finished. Everything is fixed. We just need to remove the wires and close the fascia. And we do that again with interrupted sutures using Vicryl 1. And also remove the wires on the tibial side for the ACL. And then close the skin and the subcutaneous layers with intradermal techniques so that the scar is very nice. Especially for female patients, this is important. And these are very nice scars, to be honest. They're hardly visible after 1 year. Steri-strips, sterile dressings, and a compressive bandage. So that's it. So that was a live demonstration of an ACL reconstruction using a hamstring quadruple autograft together with reconstruction of the anterolateral ligament. Thank you for watching.